I mean, if I can't do it now, I'll never do it.
No, that's the thing. It becomes very hard.
As a cardiologist, one of the funniest stories I ever heard, because he's probably about 250 pounds and not much taller than me, and a patient says to him, he's like, "I can't listen to you. How can you be my cardiologist? You're so overweight." And it took that sort of gut punch for him to really take it seriously.
I have to tell you, the patients totally notice, and they ask, like, how do you do it? And I use specific technologies and apps and things like that I could actually speak somewhat intelligently about, because I tried ones that worked, tried ones that didn't work, and it, I think, helped them in the end across the board. But it was easier at that point to kind of tell them.
I mean, it gets to the issue of bias. We are biased by the people we deal with. For example, we see patients that are overweight. It's hard for us to often understand how somebody can let themselves go that much. And similarly, they see us, and if they look at us and we're giving them advice and we're not in the best of shape, they immediately say, "Oh, this guy doesn't know what he's talking about."
Yeah, but it's hard all around. I had this patient the other day, I think I was telling you about before, where he was really, really big and was referred for a procedure, and it was pretty apparent that the coronary anatomy needed to be dealt with because of what he was presenting with. But at the same time, the assumption would be that he really let himself go, and that was what it was.
No, right.
You then speak to him and his wife, and they had tried to see 4 different nutritionists, but they couldn't get in for a variety of more logistical or operational reasons. Had been trying to see doctors, had actually knows A1C like that, had gotten it down a fair amount, and said, "I still have a ways to go, but it's gotten better," and supremely motivated to do things. And I think that a lot of people just walk into that room and they see the picture and they assume something that's probably not entirely true.
Yeah, well, when we talk about it, it's sort of the from the door test.
Yeah.
A lot of our surgical colleagues talk about that when they decide if they're going to take a patient to surgery or not. If you look at them from the door and if they look like they're a good candidate, then you take them. And so many times we lose a lot of the detail when we just look at that 60,000 foot view. And it gets to the biases we all have. I mean, we get patients like this all the time who we say, they let themselves go. For example, in the space of peripheral vascular disease, patients who have critical limb ischemia historically have been felt to be underprivileged or sociodemographically repressed people, when in fact there's really average people who just have medical illnesses that are significant. For example, diabetic patients. Yeah, right.
My aunt.
That's right. Your 90-year-old aunt who was healthy her whole life until she developed critical limb ischemia. And same thing for my uncle and people who are hard chargers and hard workers their whole lives. Tax-paying citizens who then, because of the disease process, wind up developing what's considered a disease of the poor, and consequently get undertreated. And it just gets to the bias. There's all kinds of things that we deal with all the time.
I mean, I think the other thing too that is worth mentioning though is, a lot of times people take a look at us too, and they think that we're biased one way or the other.
For sure.
Like you show up with scrubs and the doc's going to operate, and then we start talking about weight loss or various ways to improve the glycemic control and that sort of thing, and they're kind of looking at you like, wait, where is this coming from? We came for a procedure, but in reality they're coming to get better, and so. I think as an interventionalist, it's actually nice to be able to walk both of those things, the procedural as well as the non-procedural, because sometimes the non-procedural folks can't necessarily know the details of the procedures. The surgeons, for instance, only know the procedures; they don't know the other stuff as well, potentially, arguably. Whereas we can kind of bridge that gap a little bit.
Well, that's the nice thing about being an interventionalist. You're a doctor first, and an interventionalist second, often. And I think there's nothing wrong with saying that and doing, walking that walk and talking that talk.
Whether you wear the scrubs or the suit.
No, it just depends on what day. If you're in the cath lab or in the office.
I think at the end of the day, though, it's actually, if you ask the individual docs how they would take care of individual patients, there's a lot more convergence, even in views that seem to be very polarized. Maybe there's style differences one way or the other, and obviously the reimbursement scheme may influence some of that as well, on both sides, by the way. But at the end of the day, if you bring it back to the patient, I think it tends to work itself out.
I always use the "if it was my mom" test.
Exactly.
If it was my mom, what would I do? And usually I get the same answer. It's hard to overcome those biases. I don't know. I don't think there's any easy way around it.